So much, Rochelle. Hi, everyone. My name is Parya Saberi. I am a professor in the Division of Prevention Science here at UCSF. And we're gathered here for our Insights series, which is the Innovative Non-Traditional Healthcare Settings in HIV Research lecture series. And the purpose of this lecture series is to provide our community of researchers with the space and time to hear about other innovative research that's conducted outside of a traditional healthcare setting. So it could be pharmacies, patients' homes, mobile vans. And we are very lucky to have been funded by the UCSF CFAR Boost Award. And we're doubly lucky to be joined by Dr. Alex Dubov, who is a associate professor in Loma University Department of Behavioral Health and Pharmacy. I just love how they have behavioral health and pharmacy together. And his research includes studying patient preferences to improve the design and implementation of HIV prevention programs. And currently, he's leading studies to increase the uptake of PrEP in coordination with substance use treatment in emergency departments and community pharmacies. His lecture today is titled Beyond the Clinic, Expanding HIV Prevention Access Through Community Pharmacies in Southern California. And without further ado, please take it away, Dr. Dubov.
Thank you for this introduction, and thank you for inviting me. It's a privilege to be one of the speakers. And I wish we would have behavioral health and pharmacy together, but it's two different departments. I just happen to be in both. So I can also add that I'm Ukrainian, if you try to guess by my accent. For the past year, and I've also working with Ukraine back home and substance use during the war. I see two of my collaborators joining me as well, so I don't know if I can put them on the spot, but it's a privilege to work with Dr. Randy McDonough and Dr. Jessica Koch. I would love to introduce them as well since they joined. Dr. Randy McDonough, he is a pharmacy owner in Iowa, faculty member at Loma University, and he was also president of a American Pharmacy Association. Randy, can I ask you, sorry, putting you on the spot, can I ask you to say a few words?
Sure, Alex. Thank you. I appreciate the introduction. As Alex says that, I've got kind of a diverse background. I do own several community pharmacies in Iowa, 9 sites to be exact. And I've been teaching at Loma Linda since right before COVID. And I've been privileged to be part of this research team with Alex to help implement HIV PrEP and PEP and into community pharmacies where we hope the access to patients is improved and that the community pharmacists and their staff can help patients get the appropriate treatment that they need. So I appreciate being on this. Thank you.
Thank you, Randy. And also how Dr. Jessica Koch. Jessica, can I put you on the spot as well? Say a few words.
Sure thing. So I'm an associate professor of pharmacy at Loma University. My training's as a psychiatric pharmacist. So initially came in from more of a risk reduction aspect, but have been a lot more involved with the various aspects of the project and learned so much from Alex and Randy.
And I'm learning from both Jess and Randy because I'm not a pharmacist by training. My training is in behavioral health, so I appreciate having these great collaborators, and I'm so glad they were able to join. For my presentation today, I wanted to talk about the project we have, and the presentation is entitled Beyond the Clinic, Expanding Prevention Access Through Community Pharmacies in Southern California. What I would love to talk today is to start with sharing survey findings in its very preliminary findings. We just finished the survey of 350 California pharmacists, focusing on their PrEP knowledge, barriers, and facilitators to implementing PrEP and PEP in pharmacies, and the influence of implicit and explicit biases on PrEP-related decision-making in pharmacies. So I'll share some preliminary findings of the survey together with the way biases may impact decision-making of pharmacists related to PrEP initiation. I would like to give a brief overview of our project sponsored by the National Association of Chain Drugstore Foundation. I would like to share some challenges and solutions that we found in implementing PrEP and PEP in pharmacies and community pharmacies in Riverside and San Bernardino counties. And I'll share some implementation data about progress and our planned next steps. As I said, we had a survey of 350 California pharmacies. Our hope was to better understand what level of knowledge pharmacists have regarding PrEP initiation in pharmacies, regarding the legislations that are relevant, and also their comfort level with PrEP, PAP, including injectable PrEP, and also understand the influence of biases on decision-making about PrEP. So here's the overview of demographics. We had the average age of participants was 37 years. It ranged from 22 to 64 years. 51% of the sample was men and 49 women. 10% identified as Hispanic. 63% were white, 21% Asian, 15% African American. Pharmacists had multiple roles. The majority were staff pharmacists, 54% of the sample. We had pharmacy managers, 23%, clinical pharmacists, pharmacy owners, director of pharmacies, consultants, pharmacist, and regional manager in this order. In terms of the practice setting where they practiced, 41% of the sample, almost half, were coming from a retail community pharmacy. And that was especially exciting for us because the project is sponsored by Chain Drugstore Foundation. And we noticed in our project that the way PrEP can be implemented in that setting differs from the independent pharmacies. So 32% of respondents were from privately owned pharmacies and 28% were from specialty pharmacies. In terms of PrEP dispensing practices, 49% currently dispensing PrEP, 23% not dispensing but working on that, 16% not dispensing, and 7% dispensing in the past, and 3% were unsure. I guess by dispensing, that was basically any familiarity with offering PrEP, not necessarily prescribing alone. There was a special question about it as well. In terms of PrEP knowledge, looking at the sample, 52% of the sample, so 182 respondents, said that they extremely or moderately familiar with PrEP. But it was interesting to look at the breakdown because aside from self-reported knowledge, we also had a few questions in the survey asking factual knowledge, actual knowledge of PrEP regarding PrEP effectiveness, PrEP, what kind of medication is used for PrEP, what populations are eligible for PrEP, what is the recommended follow-up frequency, what are most common side effects of PrEP. And so the breakdown of responses among those who said that they familiar with PrEP, only 6% answered all the knowledge questions correctly, only 11 people. And so you can see the breakdown of knowledge question answers, correct answers. So for example, for PrEP effectiveness, we asked the percentage of effectiveness 90 and above, effective in preventing HIV 75 to 90 and so on. And so only 40% knew the correct answer. For PrEP medication, we listed multiple medication, but we also added, aside from Discovery, Twoard, or the components in the medication, we also added some that are used for ART, and that apparently also tricks some people. In terms of eligible population, some people thought that PrEP was also for people who were recently exposed to HIV, unfortunately. So that was a common mistake among people who thought they knew what PrEP is. In terms of follow-up frequency, some people thought it's less or more than 3 months. And in terms of common side effects, some people thought, for example, the liver problem were one of the side effects. We ask pharmacists what are the tasks or what are the most difficult tasks that they have among all the tasks that the clinical tasks that go into initiating PrEP. What are the tasks with the greatest need for support, or basically how comfortable or uncomfortable they are with various tasks that pharmacists is required to perform in order to initiate PrEP. And so the top 4 tasks that pharmacists were most uncomfortable with and that needed, where they needed the most support was determining PrEP eligibility, both for sexual behaviors, basically asking sexual history, and determining eligibility based on drug use. They were also uncomfortable with performing the point of care HIV testing and discussing HIV test results. So these were the top tasks. You can see that where pharmacists thought that they would need more support and more information. Aside from the difficulty in performing tasks, we also ask about barriers and facilitators for PrEP initiation in pharmacies, asking pharmacists to rank what are the kind of the most impactful barriers versus least impactful barriers for them to, if they don't have PrEP prescribing practices yet, to initiate that or to start that. You can see all the barriers that we listed in the survey, and the top 3, the high impact barriers were financial unsustainability of the PrEP service. That was the highest impact for 63% of the sample. The fact that PrEP is time consuming and it disrupts PrEP initiation, disrupts workflow of a pharmacist. Was for 53%, it was the high impact barrier. And third most impactful barrier is discussing HIV risk. 40% of the sample thought it's the high impact barrier for them. The rest of the barriers were moderate to low impact for pharmacists. They also were listed in the order of ranking for the sample. So lack of management support, PrEP is outside of pharmacist skill set, ethical concerns about initiating PrEP or providing PrEP medication, lack of private space in pharmacies, pharmacist team lacks knowledge about PrEP, concerns that patients will not discuss PrEP because of stigma related to HIV and substance use. And the least impactful barrier was uncertainty about referrals, where to refer people who will initiate PrEP in the pharmacy. In terms of facilitators, the top 3 most important facilitators or factors that would help pharmacists initiate PrEP in their practices. Number 1, again, was financial sustainability models. 62% of the sample thought that's the most important facilitator for them. They wanted self-screening for PrEP eligibility or finding some other ways to determine eligibility for PrEP, where they would have more support for those type of conversations that they apparently feel uncomfortable with. 48% of the sample thought that's the most important facilitator. And the number 3 was training pharmacy technicians to support PrEP services, was 36% of the sample thought that's important. And then you can see the rest of the facilitators were referral protocols to local partners, remote PrEP navigation support for clients who initiate PrEP, availability of private counseling space, training and written resources to support them in PrEP initiation, so like manuals, guides, kind of pocket cards to know what to discuss during the PrEP initiation conversation, consulting clinicians for challenging cases, ability to call somebody and ask for help when the challenging cases presents in the pharmacy. And the least important facilitator was stigma reduction interventions in the pharmacy, which is interesting because I'll present data on stigma next. We asked about likelihood of prescribing PrEP in the next 6 months. It was interesting to see, or encouraging to see, that 43 respondents, or 12% of the sample, they said that they already prescribed PrEP in the pharmacy. And aside from that, only 8% said that it's extremely unlikely that they will prescribe PrEP. 17% thought it's unlikely. Almost half of the sample, they believe it's possibly they will start prescribing PrEP, and 20% thought it's most certainly. So obviously there is interest, and given support that would align with facilitators mentioned in the previous slide, 43 and 20% would translate in more pharmacists doing this or offering this service. So that's just a basic overview of the responses related to PrEP. I could also mention that we also asked about likelihood of initiating injectable PrEP, and 65% of the sample, they said that they would be interested in initiating injectable PrEP, given that if there will be enough support for that type of service. But I would want to focus a little bit on the data related to implicit and explicit bias, and I'll start with just definitional reminders rather. That implicit bias is when we have negative attitudes toward people or associate stereotypes with them without our conscious knowledge of the happening, versus explicit bias is when we consciously hold negative attitudes leading to discrimination and prejudice against people who use substances, since the focus of the bias inventory in this survey was on people who use substances. And we thought it's important to include this in our survey because obviously negative stereotypes held by pharmacists can influence the way they approach people, have discussions, interpret patient behavior, interact with patients, and make decisions about PrEP. In part, this work was also modeled by our previous work, where we looked at the decision-making of primary care clinicians and the impact of these biases on decision-making of primary care clinicians. And it was interesting to find that only a small percentage of primary care clinicians were unbiased when it comes to people who use substances, and how much influence these biases were having on the decision-making about PrEP, initiation PrEP in the primary care. So we were interested to see whether there's something different or similar about this implicit and explicit biases when it comes to pharmacists comparing to primary care clinicians. Since one of the assumptions of initiating PrEP in pharmacies is that pharmacists are the most trusted profession, they were more approachable, and that clients who may be reluctant going to primary care would come to pharmacists for this type of service. And so it feels important to see whether or not implicit and explicit biases have some sort of influence on decision-making of pharmacists. So we had we included two brief inventories measuring explicit bias or explicit stigma towards LGBT or towards gay men. So we measured by a 5-item attitude toward gay men short scale, ATGS. You can see alpha, Chromebook alpha. And we measured attitudes towards people who inject drug, using explicit prejudice against people who inject drug scale. It's 6-item inventory, Chromebook alpha 084. And it's encouraging that, interestingly, that both inventories kind of yielded very similar results. it's nice to see that strongly negative views were only held by a very small percentage of the sample, but more than a third of the sample had somewhat negative attitudes towards both people who inject drugs and gay men. And I think this is in terms of support for the work that we're trying to do, all of us in the community and retail pharmacies, to help them be more efficient and effective in initiating PrEP and offering these services. Some interventions can go towards changing this percentage. And you can see the rest of the sample, 36% had, or 34% for injecting people who inject drugs. They had somewhat positive attitude, and strongly positive attitudes were between 23 and 27%. So this shows that there is some work to be done in order to remove these attitudes. This data is very preliminary, I believe I mentioned, but I'll mention again. We finished this survey only about 4 weeks ago, so this is data still in analysis. So that is very preliminary, but it was interesting to see whether there is some correlation between this level of stigma and any of demographic characteristic or any pharmacist characteristic who is more or less likely to have these types of stigma towards both gay men and people who inject drugs. And among a few predictors, race was the strongest predictor, leading to higher stigma among white pharmacists. You can see the strength of association. Years in practice, the more years in practice led to lower stigma levels in both cases. And being Hispanic also resulted in lower stigma, which is encouraging and interesting. Aside from explicit bias inventory, we included implicit association tests to measure pharmacists' implicit bias towards people who inject drugs. And there are several reasons to include this inventory. It usually has good reliability. It's been used in many studies. It captures attitudes distinct from self-report, has good psychometric qualities, and has good predictive validity. And we used 7-block implicit association test, counterbalanced. You can see the example of a screenshot of the inventory. We used images as a target, so depicting people who inject drugs versus people who who read the book. So we just chose some neutral activity. We used words as a target, help versus punishment. So help was care, protect, and all the synonyms of help. And punishment was penalty, jail, and words that associated with punishment. And the inventory took about 5 minutes to complete, 5 to 7 minutes. So the implicit association test usually measures using D-scores. It's a measure of strength and direction of implicit bias. You can see the breakdown that scores between 0 to 0.15 is no bias, 16 to 35 is small bias, 36 to 65 moderate bias, and 66 or higher large bias. And so in our sample, we had these scores ranging from 46 to 60, measured by 95% confidence intervals. The mean score was 0.53, suggesting moderate to large bias, also measured by Cohen's d. So the whole sample as a whole also has moderate to high bias against people who inject drugs in the pharmacy. It was interesting also to see whether or not there is some alignment between implicit and explicit bias. And even though there was a significant part of the, obviously, of the sample who reported not having explicit bias, among those, obviously, a lot of people had implicit bias against people who use drugs. So you can see that only 9, almost 10% of the sample were unbiased completely when it comes to people who inject drugs. And I think that's important finding to show that somebody who comes to a pharmacy has probably only 1 in 10% chance to encounter a pharmacist who's not explicitly or implicitly biased. And that's also suggests that the need for interventions to help pharmacists be aware of these attitudes and help them to offer this service in unbiased manner. We also wanted to see whether there is influence of biases on clinical decision making related to PrEP initiation, whether these biases may influence several clinical decision-making processes or thoughts related to PrEP initiation. So for that reason, we had between subject design, having 3 mock-up charts exactly similar, except in those 3 scenarios, the only difference was the level of HIV risk, or rather the type of HIV risk the patient had. So in one scenario, it was a heterosexual patient who has HIV positive partner not in treatment. In the second scenario, it was a gay man with HIV positive partner not in treatment. And the third scenario was a patient who inject drugs, or a person who inject drugs who comes to ask for PrEP with no current sex partners. The person injects heroin daily and occasionally shares needles. Everything else was identical. You can see the mock-up charts. It was a man in mid-30s, otherwise healthy, seeks prescription for PrEP, and from social behavioral history, you can see that no other partners for those few first 2 scenarios, condom use inconsistent, and typically drinks beers, and no alcohol drug use otherwise. And patient who inject drugs had no current sex partners. And so we, again, the data is really very preliminary. So this kind of mean comparison between these 3 scenarios. So we asked first in one scenario in each scenario to evaluate patient HIV risk without PrEP. And it's interesting to see that among these 3 scenarios, correctly, patient who inject drugs has high risk for HIV. We also asked to assess HIV risk for the same patient when this patient was already 1 month using PrEP consistently. And it's nice to see that pharmacists believe that PrEP reduces risk, HIV risk, but you can see that they still believe that for patients who inject drugs, the risk remains quite high comparing to other scenarios. We asked about anticipated adherence for these 3 patients to basically to see whether or not pharmacists believe that these patients can sustain PrEP use for 3 months, at least 3 months, with at least 4 doses each week. And the highest confidence in adherence for patient was for a heterosexual patient, followed by a gay man, and the lowest confidence was in the person who inject drugs. We also asked to pharmacists to suggest whether or not they would prioritize care or prioritize request of this patient for among all other patients that they have, for example, for pharmacy in that day. So you can see that among the 3 scenarios, patient who injected drugs was prioritized at lower rates. We ask pharmacists to assess whether or not they believe that this patient is effective in avoiding HIV risk behaviors. And among three scenarios, again, patient who inject drugs was perceived as the lowest in the self-efficacy for avoiding HIV risk, even though you may remember from the scenario that a patient had no sexual partners, and all three patients, they came to pharmacy asking for PrEP, suggesting that they potentially pretty good at avoiding HIV risk or being careful about that. And finally, we asked in each scenario what will be the likelihood of prescribing PrEP for this patient. And again, you can see that the highest likelihood was for heterosexual patient, followed by gay men, and the lowest was for a patient who inject drugs, which suggests that biases may also influence decision-making, all these various decision-making, having and the specific stereotypes, for example, about adherence, may have influence on willingness of pharmacists to prescribe PrEP to patients. In this scenario, again, we looked at predictors of willingness to initiate PrEP, and you can see that both explicit stigma in both cases had significant influence on willingness to prescribe PrEP, together with race, again being white, was associated with less likelihood of prescribing PrEP to both gay men and patients who inject drugs. So this is just a brief summary of our project. And I also wanted to briefly also share some implementation data from the ongoing project that we have. So we work in San Bernardino Riverside areas. That's a priority. Each counties, our territory is larger than 10 US states. It's only San Bernardino County alone is larger than 10 US states, with a lot of rural territories and population exceeding 27 states. Both counties designated by HRSA as medically underserved area and health professionals shortage area. There is a significant HIV epidemic in both counties. 18% are undiagnosed. There was, in San Bernardino County, there was a 23% increase in incident HIV cases between 2014 and 2018, and with 79% of new diagnoses among non-white individuals. And Inontimpire is also known as methamphetamine capital of the US, with a lot of methamphetamine being trafficked through the area and impacting nearby communities, with some estimates that potentially 1 in 3 new HIV diagnoses can also be in one way or another related to substance use. So our project is a 3-year project, sponsored by the National Association of Chain Drug Stores. And our objective was to improve access to HIV screening, PrEP, PEP, and relevant wraparound interventions through community pharmacies. You can see our area. Not all pharmacies mapped on this map, but we have 16 pharmacies. They're quite diverse, 3 university affiliated, 3 hospital affiliated, 5 independent, and 5 chain pharmacies. So we just recently finished first phase of the project, preparation phase. In this phase, we interviewed 30 pharmacists and technicians to identify barriers and facilitators for PrEP integration and best ways to implement PrEP in their pharmacy workflows. We supported pharmacists in state-mandated PrEP training, completion, and obtaining CLIA waivers, which actually was quite a lot, especially when it comes to CLIA waivers. We also offered training and trained 10 pharmacy technicians to become state-certified HIV test counselors who have ability to test and counsel patients about PrEP, HIV tests. So basically, this would give pharmacists the ability to shift a lot of tasks to pharmacy technicians when it comes to PrEP initiation. We hired a community health worker, Spanish-speaking community health worker, who works as a remote PrEP navigator, helping pharmacists to, or helping clients first to schedule appointments, but also post-appointment, making sure that they connect to primary care and they adhere to PrEP. We partnered with Inland Empire Harm Reduction Coalition to produce 500 harm reduction kits that are distributed in pharmacies. We collaborated with the largest insurer in both areas, in both counties, IHP, to develop a billing process for PrEP services, and we held a 1-hour educational program kickoff call before starting these services. We designed also in the first initiation phase a PrEP intake and screening app. This was needed because we noticed that there is no real recommended intake form to be used in pharmacies. And when I looked through different states that do this work, in a few states, State Department of Public Health had forms that they designed and recommended to use in pharmacies, versus I couldn't find one for us. So we designed one with 24-question intake form, looking at demographic, medical history, eligibility, behavioral eligibility for PrEP, and social determinants of health. We designed an app very similar to the one designed by Parya, PrepRx. We tried to use that one, unfortunately, a little bit unsuccessful because of Salesforce. And so we have it's kind of similar app slash patient management portal. Patients can complete the intake form on their phone using QR codes in pharmacies or in the pharmacy tablet kiosk. Most of the pharmacies have like this countertop kiosks. Some have like floor standing kiosks. Pharmacists can see real-time responses on the back end in password-protected patient management portal. They can see also suggested clinical actions associated with each response to the intake form, and they can see the list of their PrEP clients for that pharmacy, where then their PrEP journey, and send reminders and basically monitor PrEP use for their practice. We also designed PrEP implementation guide. You can see a few screenshots from it's. We try to be very detailed, so you can see we break down the process of PrEP initiation, several steps, and for each step we had standard operating procedures, checklists. You can see PrEP awareness and engagement, how to create it, how to screen for eligibility, points of care testing, PrEP education, what to include in PrEP education, PrEP financial navigation, everything else related to that, PrEP prescription, checklist for that, PrEP adherence support, and second visits for returning clients. We also included multiple form templates, for example, referral template for primary care, patient PrEP agreement form to make sure that patient is aware and agreeing to PrEP, and prescription template, HIV case report form, and many others. And we also included all the primary care in both counties that prescribe PrEP that we could find, and where patients can be referred together with addresses and information. We also had several promotional campaigns. We have posters on the left designed for the pharmacy, together with a place for QR codes to have kind of indoor messaging, or in-store rather messaging. We also partnered with a promotional agency that is very effective in promoting PrEP and health services. And they launched a social media campaign using several posters, attracting attention of potential clients, and clients complete a brief form, put in their zip code where they're located, and their contact information. Our community health worker uses that to contact them and then guide them to a nearby pharmacy and help them to prepare for the appointments, and then continues to work with them post-appointment. So we encountered several challenges and tried to think of strategies to mitigate these challenges. So we noticed that pharmacists struggle, for example, with engaging in recruiting HIV vulnerable populations. So most of the pharmacies have clients that are not necessarily eligible for PrEP, older populations. So we worked on this geo-targeted social media campaign. They didn't know how to identify PrEP eligible clients, initiate conversations about PrEP. So now there is a self-check eligibility option via kiosk or QR codes, and support from community health worker, knowledge and ability to provide wraparound care. And we had the ability to also in addition to training, to techs to become test counselors, also to become community health workers. Reluctance or time constraints for HIV testing. Again, this task could be shifted to community health workers, which were trained. Challenges in maintaining intervention fidelity. We have a learning collaborative and periodic calls between pharmacies and comprehensive program manual. Integrating PrEP services into pharmacy workflows. Clients receive remote help with scheduling visits from community health worker. Pharmacists lack time to complete PrEP visits. Again, trained technicians and community health worker provides great support. We work on compensation with largest insurer and have working on the CE training on clinical service billing. Referring clients to primary care, we have referral template and list of local PrEP prescribers, and ensuring client adherence and follow-up. Pharmacists provide a warm handoff to community health workers. So we're now in just recently in implementation phase, 5 weeks so far, 60 unique clients, 35 client conversations. We initiated already about 10 clients on PrEP, mostly Hispanic, uninsured, younger, and lacking health insurance access or healthcare access, traditional healthcare access. We had also 1 PrEP request, one HIV diagnosis in the pharmacy, 1 PrEP request from a minor, which was very interesting to deal with. Some lessons learned is that there's a difference when it comes to chain pharmacies versus independently owned pharmacies. And chain pharmacies, that we had to deal a lot with concern about data sharing, point of care HIV testing, and implementing that part, which was actually significantly better for some chain drugstores. Pharmacists' interests in adding new service was a little bit different comparing to independent pharmacists who were more enthusiastic about it. We noticed that community had a very high interest in adding STI test, doxypep, and mpox vaccination. And unfortunately, none of those we could add easily, even though a lot of clients already asked us about it. We noticed PrEP hesitancy among undocumented participants. They were a little bit afraid of state forms due to political climate. Pharmacist preparedness, so we had to remind pharmacists to stock and prescribe PEP, have this on hand as well. Some program hurdles, transition clients from PrEP immediate access, PrEP AP immediate access, and client support dealing with positive HIV test in community pharmacy. And so with this, I'll stop and I'll be happy to take questions or comments, suggestions.
Thank you so much, Alex. Oh my gosh, so much amazing data. So I actually, folks, if you can raise your hands if you have questions, or if you want to put them in the chat, please do so. I'm just going to kick this off with, I have 2 questions actually. So and I apologize if you went over this because some parts was small fonts, I wasn't able to read it, but given the really big impact of stigma on pharmacists prescribing or being willing to prescribe, what was the stigma training that for the second project that you described, what was the stigma training that they received?
We didn't really have specifically stigma training. We tried to incorporate it more. So in the beginning, we had 1 hour kind of kickoff call where we tried to focus on stigma a lot. In a kickoff call to prepare pharmacists before they start this service. And then we now have ongoing kind of check-in calls where we try to incorporate periodically reminders about stigma into the way we check in with them and ask about their needs, but also try to have reminder. So we didn't really incorporate like formal training related to PrEP stigma. Oh, I mean, substance use stigma.
Okay, I mean, I'd love to talk to you more about that because actually this is one thing that these two students of mine did a project between UCSF, UCI, and UCSD, and stigma was sure enough the biggest predictor of student pharmacists going on to later prescribe PrEP. And so it's been a big topic of discussion of, maybe instead of needing knowledge, there's more need for stigma training actually. And the knowledge may be more secondary, and that stigma should be more front and center for training. So I'd love to talk to you more about it to see if there's possibility for training.
Definitely, yes. We also have some thoughts already, but like didn't start anything yet, and would be glad to collaborate and see how we can help each other.
Yeah. And the second question I had before, Abu Bakr, I'll hand it off to you, is around the whole financial sustainability model, because I feel like you're probably one of the few people that I know who's actually attempted and has been successful in figuring out financial sustainability for pharmacies and how they can get reimbursed for their time. And I was just wondering, that's been a big topic during these lecture series. And I was wondering if you could talk a little bit more about how you went about doing that and how that's going.
Yes, I can add a few pieces of information. Maybe Jessa has been incredibly helpful in this as well, together with Randy. So we have ongoing partnership for other projects with IHP, which is the largest insurer in the county. Like they have over 1.4 million, I believe, clients in both counties, and a lot of pharmacies and pharmacists working with them. So we had several calls with them, and in the beginning, they while the pharmacy services within the insurer, within the company, they were interested and excited about this, but they didn't really believe that the leadership will necessarily be as supportive. And this is because something that I learned just recently, because apparently they wait for all claims later. Legislation alone is not enough, and somehow we didn't know that. And so, but despite that, after several months, quite a few months of nagging and kind of pharmacists working with the leadership, they added CPT codes to that they use now for other pharmacy services to also to be specific for PrEP service. So I would be interested to know, we're trying to find if there are any other insurer who's done it. So far, I couldn't find other insurers, but maybe if somebody knows of other insurers who already compensate pharmacists. So they added CPT codes. Unfortunately, time I think is limited to for a client visit for first is 30 minutes and then second visit is 15 minutes. But they said it's a good start, and we can later argue that it potentially takes a little bit longer. It should result in higher compensation, but for now, that's still better than nothing. They compensate as suggested 85% of clinician rates. And in meanwhile, and for those, if somebody has pharmacists interested in this project and want to join us, we still accept and will be willing to interested in supporting other pharmacies. We still have funds in our project where we compensate pharmacists from the grant funds for each client for the service provided specifically. So that was something that our funder was willing to do. So the idea was that we start compensating pharmacies that work with us, but then transition them to for sustainability piece to insurer. So which now we happily can do, because now at least one biggest insurer in the county has CPT codes that we can and process. They send the guidance to all pharmacies on how to use it.
Thank you. I'm just wondering, Jessa, is there anything you wanted to add to that since?
Jessa or Randy? Yeah.
I don't have anything further. I don't have anything further to add. When it came to talking with IHP, it ended up being a good time that they were going forward with the implementation of the other pharmacy services. So just making sure that PrEP was added. And then I would say just continued advocacy, because there is still concern that with the time limitations, again, that the reimbursement might not be allow for the sustainability. So really continuing efforts for as much reimbursement as possible for the services that pharmacists provide.
Great. Well, I hope you'll publish that because that's really important information and so much needed. Abu Bakr, please go ahead.
Thank you very much, and really it is a very great presentation, Alex. Congratulations on that. I have two questions. One regarding, I think you have mentioned in the first part of the presentation that the pharmacists, they reported some difficulties in determining the eligibility of the patient or the PrEP candidate, either they are drug users or regarding their sexual behaviors. Yeah, but I would like just to know that did you account for this report with regard to their decision making you have made at the end of the presentations? Another thing that also you reported a different level of implicit and explicit bias, and did you also account for this with regard to the decision making you had made at the end of the presentations? Did you consider, for example, those with moderate or low or high implicit or explicit bias, this affect the decision making, or you take it as general results or the general score?
So yeah, I believe we looked at, I reported only a few pieces where like we noticed a significant difference between three groups, how they make decision making about PrEP, but eligibility was not necessarily one of the pieces that we asked in those three scenarios, because they already knew whether or not clients, what kind of risk they had. But we assume that that can be significant barriers, or that can be actually a root of the hesitancy why they're so uncomfortable and in initiating these conversations in the first place. So while we not necessarily look specifically, but seeing how uncomfortable they are with that conversation and seeing high levels of stigma and bias related so that my assumption is that it just potentially the two can be related. So we not necessarily looked at that specifically, but it's a high probability that the reason why they're so uncomfortable is, or the stigma can be better in that specific step of PrEP initiation.
Thank you. Alex, also in addition to lots of congratulations from Laura Dean in the chat, there's a question from Reza Beltran. I'm just wondering, Reza, do you want to just come off mute? Because I know I see two questions in here.
Yeah, hi, Alex. I know Alex. So I'm Riza. I was a postdoc at UCLA and worked on the same topic. Yeah, Alex, I just wanted, I may have missed like how many pharmacies you're working right now, working with right now with the Inland Empire. And also secondly, I know there's been kind of an issue with pharmacies on collecting data, patient record data. Some of them may not be as used to that and providing that data to other providers. So just those two questions. And great work, Alex.
Thank you. So 16 pharmacies so far, and but we're still working with a few, and again, open to anybody else who in the area and wants to join us and willing and interested. Was the second question, that was one of the reasons why we actually wanted to have this patient management portal or something for pharmacists to have this information collected systematically, given that they all have different ways, or maybe none at all, of recording patient information more systematically. So at least for PrEP, when it comes to PrEP, there is a way to do that. And if they want, if they have their patient management system, that then they can, there is an option in the patient management management portal to have PDF of the patient responses or printouts to be scanned into their patient management records. So there's a way to transfer those.
I'm sorry, Alex, really quickly. So you essentially you collect the data. I mean, you have the system within your own, and then they can just access that. So you're the one collecting. Okay, got it. Okay.
Right. Yeah. So that's like the app that we, with the intake form, but also was like that. It's saved on the back end together as like where a patient is in their journey. So that's what we use. And if they have other ways to, collect, or if they have already a patient management system, then they can, basically transfer this record to their own. In terms of sharing the records, we have a provider referral template. So that was one of they didn't know how to use. So we basically just created a template for them that they can use and fax it. They had preference for faxing. Everybody has fax apparently. So we just have this template where they can easily fill it and fax it to providers.
Thanks, Alex. And then just one final question from Kenneth Joseph, who says, great presentation. Out of the 12% that already prescribed PrEP, did that account for the prescribing oral and injectable?
No, we didn't ask specifically. We just asked in general for oral. Yeah. So, I guess the implied was that oral because it was an oral PrEP section. And then after that question, we transitioned to injectable. So I don't think the assumption was that it's both oral and injectable.
Is there any injectable happening in these pharmacies right now?
To be honest, no. It's possible we designed a workflow for a few that could actually do that, and we figured out like how to buy and bill procedures and how to basically help them to do that. So in theory, it's possible. In practice, we hope to get funding to actually implement that.
Yeah. Well, thank you all so much. We're right at the top of the hour. So another big round of applause for Alex, and great work, and so excited to hear about your future projects and where you take it with this. And please come back and visit us again soon.
Thank you. Thank you for the invitation. And thank you, Jess and Randy, for joining as well.
Thank you, everyone. Take care.